Welcome everybody to a new presentation in a series of presentations discussing the role of dentists in diagnosing systemic diseases from the intraoral radiographs. And today, our presentation, we will be discussing the endocrine disorders, and in particular, we will be discussing the hyperparathyroidism. Before we go into the disease, we have to know the hyperparathyroidism as a disease is a disease of the parathyroid glands, and those glands are two pairs of glands. So actually there are four glands altogether, which are positioned behind the left and right lobes of the thyroid gland. Each gland appears like a lentil the lentil seeds, which is yellowish brown, flat structure, and they measure about 6 millimeters length, 3 to 4 millimeters in width, and they are about a millimeter in to 1 millimeter to 2 in depth. As for the weight of the glands, each gland weighs around 30 milligrams in men and 35 milligrams in women, and the glands are not visible, so they are not on the superficial surface of the thyroid gland. They are located behind the thyroid gland, and thus they are not palpable or visible during the examination of the neck. This is a presentation of the gland, where you can see this is the thyroid gland. The two pairs of the gland, they are actually superior and inferior, two on each side. So collectively they are four glands, yellowish in color, with the dimensions that we've talked about, and they are located, as we said, on the back surface of the thyroid gland. Thus they are not palpable. As for the function of the glands, of the four glands, each of them is responsible for the secretion of the parathyroid hormone, or sometimes it is called the parathormone, or which is abbreviated as the PTH. The parathyroid hormone acts in maintaining the serum calcium and phosphate levels. Those two, the calcium and the phosphates, are responsible for the proper function of the nervous and the muscular system. The parathyroid hormone takes part in the control of calcium and phosphate homeostasis, as well as the bone physiology. And the hormone, the parathyroid, it increases the blood calcium levels by directly stimulating the osteoblasts. Thus, this will indirectly stimulate the osteoclasts to break down bone, and thus they will release the calcium into the bloodstream. The parathyroid hormone increases the gastrointestinal calcium absorption, the uptake, by activating vitamin D, and it promotes the calcium resorption, the calcium reabsorption by the kidneys. So it takes back the calcium again. Parathyroid hormone is a major regulator of the serum phosphate concentrations by inhibiting the proximal tubular reabsorption of phosphorus in the kidneys. And the parathyroid hormone activates the intestinal vitamin D absorption, and thus it increases the phosphate blood levels. So it acts on many locations to increase the calcium and phosphorus in the bloodstream. Normal calcium levels, now we're talking about the blood biochemistry. The normal calcium level, they range from 8.5 to 10.5 milligram per deciliter. The alkaline phosphatase level ranges up to 100 international unit per liter. The parathyroid itself, the PTH, the parathyroid hormone, normally its level is 15 to 65 picogram per milliliter, while the normal phosphorus ranges from 2.4 to 4.1 milligram per deciliter. Any increase in this, it means that there is a function in the parathyroid hormone. The disease itself, hyperparathyroidism, it is present in women more than in men, 3 times in women, the rate in men, and it occurs in the between the third and the sixth decade of life, characterized by an increase or excessive circulating parathyroid hormone, so level is increased. The increase in the excretion of the parathyroid, it will lead to an increased bone remodeling, which will lead to an increased osteoclastic activity. So the bone resorption is increased. This will lead to calcium ion being mobilized from bone, from the skeleton, into the bloodstream. The parathyroid hormone also increases the renal reabsorption of calcium and renal production of vitamin metabolite. This, as a net or as a sum, will result in an increased serum calcium levels. And when the blood calcium levels are high, the parathyroid hormone should be low. So it's a reverse relationship between the two. Generally speaking, hyperparathyroidism means an increase in the bloodstream of calcium and phosphorus. As for the clinical features and the symptoms are caused by the abnormal or elevated blood calcium levels, and this is of course to a response to the increased production of parathyroid. Kidney stones may result in a long-standing hyperparathyroidism due to the excessive reabsorption of calcium, bone pain, weakness, depression, confusion, and increased urination. Long-standing disease may cause or lead to the formation of osteoporosis as a complication, and the diagnosis of the primary hyperparathyroidism is made by finding elevated calcium and parathyroid hormone in the blood. Both of them are elevated. As for the teeth, this will lead to the gradual loosening, drifting, and possible loss of teeth in a long-standing or as a long-standing effect of the disease, and we will know why once we see the radiographs. The disease is divided into 3 stages. The first one is the primary hyperparathyroidism. And this is a result of the adenoma, that is a tumor of one of the 4 parathyroid hormones, which subsequently leads to the excessive production of parathyroid hormone. The disease would be categorized as primary if there is hyperplasia, or as a result of hyperplasia of the parathyroid glands, which is also will be leading to an excessive production of the parathyroid hormone. Hypercalcemia and elevated serum parathyroid hormones are characteristic of the primary hyperparathyroidism. Not only these two increase in the blood, but there is an increase in the serum alkaline phosphatase, which is an indicator of the bone level turnover. It also will be increased. Now this is a diagram of the normal, the one on the left. You can see that they are normal in size as it was described earlier. And on the other side, we will have adenoma, a tumor or hyperplasia of the gland with subsequent increase in the parathyroid hormone. Secondary hyperparathyroidism, on the other hand, is a result from a compensatory increase in the output of the parathyroid hormone in response to hypocalcemia. So there is a deficient amount of calcium in the blood. This will lead to stimulation of the parathyroid glands to increase more parathyroid hormone in order to absorb or mobilize more calcium from the bone into the bloodstream. Hypocalcemia may be a result from inadequate dietary intake, in which of low level of calcium, poor absorption of vitamin D, and or the deficient metabolism of vitamin D in the liver or in the kidney. Primary and secondary hyperparathyroidism would produce similar clinical and radiographic features. Tertiary hyperparathyroidism. This is a result of prolonged secondary hyperparathyroidism, which makes the parathyroid tissue irresponsive to the blood's calcium levels. So regardless of the calcium being high or low, calcium levels in the blood, the glands remain to produce the parathyroid hormone, so it goes out of control. Now, if a patient, you suspect that he or she is affected by the disease, then you would refer your patient to an endocrinologist. It is beyond the scope of a dentist to treat hyperparathyroidism, so we would refer our patient to an endocrinologist. However, we need to know or have an idea about the treatment. The treatment is actually directed towards the cause. So in cases of primary hyperparathyroidism, parathyroidectomy of the affected gland, the hyperplastic or adenoblastic gland, is removed. Secondary, we need to increase to treat the cause. And here we are going to give vitamin D deficiency, to treat the vitamin D deficiency or the chronic failure. At the same time, of course, improve the dietary intake of calcium and give the calcimimetics. The calcimimetics are drugs that can reduce the parathyroid hormone secretion in all forms of hyperparathyroidism. So we tend to decrease that secretion in order to immobilize the calcium from the bone. Calcimimetics are used as a therapy for the secondary hyperparathyroidism associated with the renal failure of those patients on kidney dialysis. Calcimimetics also can be used as a treatment for certain patients who cannot undergo the treatment of parathyroidectomy for any reason, like any reason that would prevent the diseases or enables the disease for the patient for the removal of the affected gland. Now, when it comes to the oral and radiographic features, when you see a radiograph of a patient who is affected by hyperparathyroidism, the first thing is that you will see absence, whether complete or partial absence, of lamina dura. The cortical bone, which is forming the socket of the tooth, is going to be, it will disappear. You know that the tooth is located in a socket. The socket is formed of a compact bone. Now, if the compact bone, this is disappeared by the dissociation of the bone by the parathyroid hormone, this will lead to the absence of lamina dura, and this appearance will give, or this situation will give the teeth as if an appearance as if they are floating in the jaw. There is nothing to hold them. So teeth appear to be floating as a result of the alveolar bone destruction around the teeth, around the roots definitely. Demineralization and thinning of the cortical boundaries of the jaws, especially the inferior border, it will appear thinner than usual. The mandibular canal walls, they will disappear, and the walls of the maxillary sinus will appear thinner than usual. There is a generalized reduction in the radiographic density of bone, and this is because calcium, which absorbs the X-ray and gives the radio opacity to the or the radio density to the X-ray image is reduced. So the radiographs tend to be more radiolucent. They don't have the same radio opacity as that of a normal patient. Ground glass appearance of the bone due to the change in the number and the pattern of trabeculae. The trabeculae, they will appear as a lace-like structure, whether in the mandible or in the maxilla. Now, this gives the architecture of bone. If these are destroyed or they become thinner, they will not appear as they would be. So it will be replaced by a granulation tissue, an osteolytic tissue. This will give the ground glass as if you bring glass and then you destroy it, which gives the ground glass appearance due to the change in the number and the pattern of trabeculae. And the osteolytic radiolucent areas are seen in the jaws, which are described as the brown tumors in the late stages of the disease in about 10% of the cases. What is happening here is that the normal bone is being replaced by granulation tissue. These will appear as patches, radiolucent patches in the bone, which are given the name as brown tumors. We will understand why they are given this name. The radiolucent areas, those patches, are a result of hemorrhage and reparative granulation tissue with proliferating fibrous tissue. So you don't have bone anymore, which replaces the normal bone marrow. This will give the ground glass appearance. In a gross section, when you remove the mandible, you cut it. Hemosiderin, which is a result of the dissociation of blood, gives this reddish-brown appearance in color to the lesion under the microscope, which is giving the name of the brown tumor. Radiographically, brown tumors may resemble the central giant cell granuloma or a aneurysmal bone cyst in appearance, that is the multilocular appearance. This is for the brown tumors, the patches. The bone would appear as a ground glass appearance. Brown tumors have variable margins in the radiograph and may produce expansion. This is in the jaw. As for the skull will have a characteristic appearance which is described as the salt and pepper sign. These are multiple tiny, well-defined areas, radiolucencies, in the calivaria, caused by the resorption of the trabecular bone in hyperparathyroidism. And there is a loss of definition between the inner and the outer tables of the skull, and the ground glass appearance, as well as the spotty dissociation or deossification. Now, if you see here the skull, this is a lateral skull radiograph. You can see that the plates of the skull are thick and they are well defined, and you can find the calivaria is very clear in between them. Compare it to a patient who has hyperparathyroidism. First of all, the general architecture of bone is changed. The normal bone, heavy, dense bone, will be replaced by a ground glass appearance bone. due to the destruction of the bone trabecules and the bone marrow and the replacement by granulation tissue. Plus, you will see those areas of white and black areas, which gives the typical salt and pepper appearance of the skull. And you can compare between the radio density of both. See here the radio density of the skull, compare it to the radio density over here. You will see that there is a generalized decrease in the radio density of. This is an OPG of a patient who has hyperparathyroidism, and you can see if you have a look at the lamina dura, you will see complete absence of the lamina dura. 1. 2. There is thinning of the inferior border of the mandible, and you will see that there is a well demarcated. Can you see this here? The well demarcated expansile lesion, which is affecting the angle of the mandible, extending anteriorly to the medial root of the 7, and it goes up. It has caused the superior movement of the lower 8, and you can see that it is extending up to the middle of the ramus, and then if you can see over here, there is some expansion. So this is what is known as the brown tumor. Brown tumor, this lesion is a replacement of the normal bone with a blood and then granulation and then fibrosis of the blood in this area, which gives this appearance. Now, if this is to be cut under the by the operation, sometimes if it is big, then it will give the typical brownish, reddish brownish appearance of the This is another case of a patient of an OPG of a patient who has parathyroidism. Now, if you have a look at this radiograph, first of all, you will see that there is a generalized decrease in the radio opacity of bone. 1. Second, you will see that there is generalized absence of lamina dura in all the teeth, upper and lower. 3. Have a look at the upper quadrant, upper right quadrant. You see that the teeth, they seem to have lost their attachment with the bone. So they give the appearance of floating teeth. So there is no attachment whatsoever. And 4, have a look please at the general pattern of the bone trabecules. The bone trabecules, they don't have this normal appearance which is seen in the radiograph. They tend to lose the general arrangement, and this is because of the loss and the thinning, continuous thinning and removal of calcium, so we don't have the normal appearance anymore. However, we don't expect the brown tumors are not seen in each and every case. Usually they are seen in around 10% of cases, but this is a striking appearance of the teeth. Of course, when we say floating teeth, this does not mean that this is the only case where we see floating teeth or ground glass appearance. We may see it in other diseases, Langerhans disease, for instance, fibrous dysplasia, but if this is accompanied by increased blood levels of parathyroid hormone and the calcium levels and alkaline phosphatase, this. When it comes to intraoral radiographs, the same thing is expected actually. This is a radiograph of lower centrals. See the complete absence of the lamina dura. The change, this is still appears to be a normal architecture of the bone trabecules, but here, because this is the mental ridge over here, but here, have a look at this area. The trabecules, they don't appear as they should. Another case over here, see the typical ground glass appearance over here due to the change in the trabecular pattern, and the typical absence of the lamina dura. This is and see the floor of the maxillary sinus, how thin it is. So it's almost lost. All this is because the bone does not have the same radio density as it should have it. Another case over here with a brown tumor lesion. 1, absence of lamina dura generalized. 2, the teeth, especially those 2 molars, they don't appear to be attached to the bone in this area, which we call the floating teeth. And have a look at the inferior border of the mandible in this area, how thin it is. There is also a change in the trabecular pattern of the bone. Other radiographs, which are this is a case. See the lacunae formation in this is an occlusal radiograph. This is the shadow of the tongue over here. Have a look at the bone trabecules, how thin they are, with the start of the loss of the general outline of the bone. Another case, see the central incisors. Typically, if you look at those teeth, they give you the appearances that they have no attachment. They are just placed there. 1, loss of lamina dura. No lamina dura is here whatsoever, and the absence, the complete destruction of the bone marrow spaces, which gives the typical ground glass appearance. Have a look at this area. No lamina dura. See the ground glass appearance, typical ground glass appearance. This is, as we said, it's typically because of the immobilization of calcium from the bone to the blood. With this, we come to the end of this presentation. These are the references, and I would thank you for being patient. Hope this was a good presentation. Thank you very much. Appreciate it.